Welcome, everybody. Joe's historical description is actually quite good, and I looked at the Bruegel picture, and I have another explanation for it. And those of us who have been involved in residency training for years have often had that face when you say to the resident, "You did what?" So we know that face. I've been involved with blepharospasm actually since 1982, and I was part of the original study for the FDA that Dr. Scott organized, and have been treating patients since that time. And when Joe talks about Mattie Lou, how important she was to this whole movement, I remember her importance as during the time after Botox had been on the market for a while, then there was a problem where it went off the market and it was unavailable in this country. And I never had more unhappy people in my practice than that particular time. And she was so influential in making the drug available again and getting people treated again. That was one of her many achievements for which she is obviously well known. Now, Joe talked about a variety of disorders that can look like blepharospasm, and he told you essentially the clinical characteristics. And the patients that I see very often start off with frequent blinking, but obviously frequent blinking doesn't have to be the start of a blepharospasm. And I think this is very, very important. That blepharospasm is bilateral. I've, over the years, seen many patients who have been misdiagnosed as having blepharospasm, and most of the times it's unilateral. And I never ever make the diagnosis of blepharospasm unless it's bilateral to some extent, and I would agree that it can be asymmetric. And it's not just simple eyelid closure, as again Joe said. There has to be a spasm. Remember that the second part of the word is spasm. Blepharo means lid, and it has to be spasm. So just an inability to not open the eye is not a blepharospasm. So this is an integral part for me of the diagnosis of blepharospasm. And there is no test for this. You know, it's if it looks like a duck, walks like a duck, quacks like a duck, it's probably a duck. And that's the way you make the diagnosis of blepharospasm. If it looks like blepharospasm, patients behaving like they have blepharospasm, it's probably blepharospasm. And right now, in this day and age, we're sort of, well, you have blepharospasm and we'll sort of do this, and Botox, et cetera, et cetera. When I started in neuro-ophthalmology, and I am a neuro-ophthalmologist, most of the people who had blepharospasm were thought to be psychotic. And the immediate response to someone who came into your office with blepharospasm was psychiatric referral. And I had several patients early on in the 70s who actually were sent for electroshock therapy for their blepharospasm. So things have changed dramatically. Now, there are a lot of classifications, and this is one I used for today's talk just to sort of segue into what my task was. Now, benign essential blepharospasm, there's no name that really is satisfactory to everyone. But I would call the blepharospasm that is the dystonia primary. Just for our discussion here today. So we know that we're talking about blepharospasm, which is the dystonia. There are, however, people who have spasm of their eyelids that looks for all the world like blepharospasm, like the dystonia, and it's not due to a neurologic disease, but it's due to an ocular disease or some other problem, and that's what we're going to focus on today. And as Joe showed you very nicely in the movie, there are these mimickers of blepharospasm that are the apraxia of lid opening and the tardive dystonias, etc., etc. And again, you make those diagnoses by looking at the patient. There's no, or taking a history. There are no tests for this. So we're going to concentrate on the secondary causes, and most of them are ocular. They're ophthalmic. Now, in general, the things that cause spasm of the eyelids or frequent blinking or closure of the eyelids from an ocular standpoint are caused by problems up here, up front. This is the cornea, which is the clear part of the eye that you see through, and this one structure has some of the highest complement of nerve endings in the body. I mean, you won't understand. If you get a little speck of something in your eye, it feels like there's a house in there. All right? And that's because of the high complement of nerve endings in this structure. But you can get disorders of the cornea that can cause you to close your eyes, obviously. The other part here that you can't really see is there's a clear membrane that covers this white part. That's called the conjunctiva, and the white part is called the sclera, and you obviously know what the lids are. Now, how does the eye work, and how does the eye stay comfortable so we don't have to close our eyes all the time? The tear and eyelid function of the eye is critical. And we blink approximately 9,600 times a day. And why do we blink? All right. Well, we blink for a variety of reasons. It takes away the debris that will accumulate and degrade our vision, and smooths out this surface. This is like a camera, and this cornea is the most important lens system in the eye. So if there is any irregularity of this structure, your vision will deteriorate much more than if there's an irregularity in the lens of your eye, like a cataract, or if there's an irregularity in the retina. So this is very important to keep this surface smooth. Now, what do the tears do? The tears keep it smooth and keep it moist. And what the eyelids do is the eyelids produce, the tears are produced in glands in the eyelids, but the blinking of the eyelids spreads the tears on the cornea, and subliminally, when that tear film starts to dissolve, you blink again. If you've ever tried to hold your eyes open without blinking, you first feel a little burning, then the burning gets worse and worse and worse and worse, and that's what happens as your tear film starts to dry. Your cornea sends your brain a signal, say, you better blink because something's going to happen. All right? And we'll talk a little bit in the end about the eyelashes that protect the eye. Now, the tear system, this is the most frequent cause in an eye doctor's office of people who come in with frequent blinking or eye closure on the basis of an eye problem that's not blepharospasm. And dry eyes is not just, well, there's not enough water there. Dry, not enough water. It's a little bit more complicated than that. And this is the definition that is largely agreed upon by the people who are the corneal experts in ophthalmology, that it is a disease, it's a disorder, that is due to a problem with the ocular surface. And the ocular surface is the cornea, the conjunctiva, the sclera that we talked about. And when the tear film becomes unstable, you can get damage to the cornea. And you can also get it even if there's plenty of tears there, but the composition of the tears, there's something wrong with it. It's not quite right. And the biggest abnormality is this problem with osmolarity. Now, I'm not going to get into this, but the tears are a little bit more complicated than just water. There is the major part of the tear film is water, but an important part is this lipid layer, this fat layer. Because what happens is, if you didn't have this lipid layer, the water would evaporate immediately. So when the lid blinks, it spreads the tears, and there's this very top lipid layer that prevents the air from causing evaporation of the saline fluid that is the major part of the tear film and keeps you comfortable longer. Otherwise, we'd be blinking like this all day long. So if there is a problem with the lipid layer, you will in fact get frequent blinking that looks for all the world like the beginning of blepharospasm, because these types of problems with the tear film are usually bilateral and not unilateral. And the disorder that is characteristic of this tear deficiency or dry eye is called keratitis sicca. Keratitis is an inflammation or a problem with the cornea, and sicca means dry. And this is a syndrome that is actually very frequent. It's estimated, it's more in women, and it's estimated that over 3 million women have this in the United States to a very degree. And it is a wide spectrum, and sometimes it just occurs in and of itself. Your eyes are just dry. I'm sure there are many, many people in the room who have dry eyes, and most people who have dry eyes don't have blepharospasm, but a lot of patients, in my experience, who have blepharospasm have dry eyes as well, and sometimes it can be associated with collagen vascular disease like Sjogren's, where your mouth is dry as well. And this is what happens. If there is a dye called fluorescein that if you put it on the eye, a healthy eye, you don't see anything. But when the tear film dries too rapidly or is constantly dry, you get damage to the top covering of the cornea, which is called the epithelium, and parts of the epithelium die. And the fluorescein dye is taken up by those spots. And you can actually see, when you put the dye in there, all these individual little dots that here coalesce are spots of the epithelium that are missing. And this is a problem that gives the patient a lot of discomfort, because no matter how much you blink, you can't spread the tear film enough or efficiently enough to make this better. Now, this is another dye that's used. It's called rose bengal, where this stains cells that are still there. This stains areas where the cells are missing, and this stains cells that are still there but are not healthy. So that when you go into the eye doctor's office and they think you may have dry eyes, what they will do is a variety of tests. Well, first is they'll put this dye in your eye, and this is the same dye they put in your eye to check your glaucoma. To do a glaucoma test. And then the next test they'll do may be this test called a Schirmer test, where they'll put a little strip of paper. There's a little bit in here that fits on the inside, and they'll leave it there for 5 minutes, and then they will see after 5 minutes how much of the strip you wet. And in some of these strips, there's actually a little ruler calibration on here, or you just measure how much it wets. And if it wets 15 millimeters or 20, then it's fine. So if it wets 1 or 2 millimeters, then you know that that's a dry eye. And there's a variety of ways you can do this with and without anesthesia, and I'm not going to get into that. So in addition to the a liquid problem of keratitis sicca, there's also a mucus problem. So besides there having areas that are missing, you can get accumulation of mucus strands that just hang on your cornea. And you can imagine how that can cause discomfort, and you're constantly blinking to try to get rid of these little strands, which are filaments, and these mucus plugs that just adhere to the cornea. So here's what we look at when we look at you and you put your chin in that machine, and then we look at you with the microscope. When the tears are produced, they form a lake down here. And you can actually see the lake and see how abundant it is, or how much it's defective. And we can look at that. This is the fluorescein staining I talked about. This is the abnormal area where there is drying of the cornea, and this is what the normal cornea looks like. And this area down here is typical for dry eyes. And this is, again, the rose bengal stain. And this is how sometimes it can be very minor, so you don't even notice it, and you can see these filaments on the cornea, and then other times it can be much more severe, and you can see these staining areas where here you may just see one or two spots. And this will cause frequent blinking, and if it gets very bad, forced eye closure. Now, This dry eye and the cornea are the most frequent cause, in my experience, of the real problems of eye problems that cause spasm of the eyelid or frequent blinking. Anything that irritates the front part of the eye will cause this. So if you have eyelashes, this is called dystichiasis, where you have an abnormal row of eyelashes here that you're born with, and they're turned back and they're constantly touching the eye, you can understand how that would cause you ocular irritation and you'd be blinking all the time. That's unusual. This is the more frequent type of a problem, and this is called trichiasis. And it's just that your eyelashes are in a bad position. They bend in instead of sort of bending out like this or curving up. They bend in, and here they are, and they're touching the cornea. And this can be from a whole variety of conditions, or it can just be that that's the way your eyelids go. But it's usually after some sort of problem with the eyelid. This is one of the problems in the eyelid that can cause frequent blinking. It is not the one that is the most likely to do it. Your lids usually sit flush against your eye, and if they don't, it can cause a whole variety of problems. Right here is, and here, is a structure called the punctum. And what happens when you produce the tears that coat your eye, when the lids blink, not only do they coat the surface, but they also push this tear lake towards the punctum, because that's where the tears come out. I mean, if there wasn't a way for the tears that are produced get out of your eye, they'd be running down your face all day. So it's like when you put a drop in your eye, you can taste it in the back of your throat. That's how the tears drain, normally, all right? Now, if the eyelid is not in touch with the ocular surface, the punctum is turned out and the tears can't get into it. So you will have tears running down your face, but you will have no lid function that wets this part of the cornea, and you'll get a drying of the cornea there, and you can get blinking. This is obvious to see. Now, this is a little less obvious because it can be intermittent. And here what you see is called entropion. The lid is turned in. And here you see the nice margin of the lid up here, and here you can't see it. And if you notice, the eyelashes are turned in, and they're actually touching the eye, all right? And this will cause irritation and those spots that you can stain with the fluorescein, which we talked about before. It's all a pathway that gets to the same end. Irritates the cornea. Your response is blinking and eyelid closure. And I won't get into any of the treatments about that, because Dr. Soparkar is going to talk about that later this afternoon. And this is the same sort of entropion problem that's due to scarring instead of just aging. And this is the one that is really can fool you, because this is called spastic entropion. It's not there all the time. And patients come in and they're blinking, and they say, well, it happens sometimes, and you see a little bit of staining in the cornea and you don't understand what's going on. And what I usually do is I have them squeeze their lids, and when they squeeze their lids, one eye will open and the other eye will not. The lid will stay in. And when it stays in, the eyelashes are up against the cornea, and here you see the fluorescein without that blue light where that is being taken up. So this is a defect in the cornea, and this patient actually came in because of increased blinking. And this I see mostly after bad lid surgery. You go in, you want to get your lids lifted, and somebody gets a little carried away, and your lids are lifted, and you're walking around like you're surprised about everything in life. But then what happens is that when you try to close your eyes at night to sleep, you can't. And then what happens is this dries out as you're sleeping for several hours at night, and when you wake up in the morning, this is red, and then you're blinking to try to get the tears to wet that surface again. And oftentimes, unless you have the patient gently close their eyes, you will miss this diagnosis, because when they squeeze, it will close completely. So you have to have the patient gently close their eyes. So that and this is the other thing that is often missed. This is something that's called giant papillary reaction of the conjunctiva. And what I'm doing here is we're flipping over the lid. So you're looking at the under part of the upper lid. And this is a patient that when you look at them, they look completely normal. All right? And they're complaining, their eyes are uncomfortable, they're blinking, they feel better when they're closed. And these are not supposed, these cobblestone type structures are not supposed to be there. These are called giant papilla. And this is in a reaction to, can be an allergic reaction, but we see it often in soft contact lens wearers, and this is called GPC, giant papillary conjunctivitis. So one of the things we do as ophthalmologists, when somebody comes in with this complaint, they're blinking, their eyes are uncomfortable, is to always flip the upper lid to look for this. And you can get infections of the conjunctiva and also of the cornea. And here you have a bacterial infection in the cornea, and because of the nerve endings, you understand you can get blinking. But this is pretty obvious to see. Here's another one that sometimes is not as obvious. This is an infection of the conjunctiva and the cornea. And finally, this sort of tree leaf structure is really uncomfortable, and that's a herpes infection of the cornea, and this is typically what it looks like. So, in conclusion, what am I telling you? What I'm telling you is that there are a lot of things that cause frequent blinking, increased blinking, eyelid closure that may be blepharospasm, but is not blepharospasm, and it behooves everyone before you start a variety of treatments, whether it's with a systemic medication or Botox, that the patient have a complete eye examination to rule out one of these problems that are treated differently, and they don't need to be labeled as having a neurologic dystonia and don't need the treatment for that. Thank you very much.